Thank you for joining this webinar. My name is Sybille Liautaud, and I'm a member of the Pulmonary and Critical Care Division at Baystate. I'm glad to be presenting today, and I'm also glad to join Dr. Green. Dr. Green is the founder and the director of the non-CF bronchiectasis clinic at Baystate. And he also has a special interest, as I do, in atypical myobacterial infection. And he will be covering that topic during the second half of this presentation. So let's have an overview of the presentation. I will actually go over some definition of cough, and specifically focusing on chronic cough. Then we will talk about different causes and common causes of chronic cough, and how do we evaluate a patient who present with this type of complaint. We will then focus on bronchiectasis, going over the definition, the diagnosis, and the management. And as I mentioned earlier, Dr. Green will discuss what are atypical mycobacterium infection, how do we diagnose them, and how do we treat those patients. So what we need to understand is that cough is not a disease, but a very common symptoms that can be a manifestation of either an upper or lower respiratory tract disease. Cough also has a very important role in actually protecting our airways. It helps clear particles and secretions from the lung. Cough can be defined as either being acute, subacute, or chronic. So an acute cough is a cough that is that someone has for less than 3 weeks. And very common causes of acute cough are common cold, acute bronchitis, and occasionally it can be a manifestation of an exacerbation of a chronic condition such as asthma. The subacute cough is a cough that lingers a little bit longer, typically for about 3 to 8 weeks, and very often can be post-infectious. After a common cold, after the flu, we can have a persistent cough, and we've seen over the past 2 to 3 years many patients after COVID-19 presenting with a persistent cough that simply does not go away. And again, the subacute cough can also be a manifestation of an underlying chronic disease. A chronic cough is a cough that lasts much longer. Typically, we start talking about a chronic cough when one has a cough that lasts for 8 weeks or more. The most common causes of chronic cough are typically postnasal drip, asthma, and GERD. These 3 causes, in fact, are responsible for up to 90% of cases of chronic cough. Less common causes of chronic cough are infection, use of certain medication can actually cause a chronic cough, and lastly, different type of lung disease. We talk about postnasal drip when we have secretions coming from the upper airway, from the back of the nose, and dripping into the throat, causing an irritation that provokes a chronic cough. Asthma is actually the second most frequent causes of chronic cough in adults, and is actually in children is the leading cause of cough in children and adolescents. In addition to coughing, if someone has asthma, they would also experience other symptoms. They will report at times wheezing or having shortness of breath or chest tightness. GERD is another very common cause of chronic cough. Many people can actually report heartburn when they have GERD associated with cough, but sometimes a cough can be actually the only presenting symptoms of acid reflux. And in that case, it may be sometimes tricky to be able to actually establish the diagnosis and know that this is actually the cause of the cough. So when one sees a patient with chronic cough, there are different approach to try to establish the cause of the chronic cough. First, it's very important to have a very detailed history, trying to look for clues for the most common causes of cough. Other investigations that will be often requested depending on the history and on the suspicion for a certain diagnosis. We may sometimes ask for a chest x-ray. We can also sometimes request a pulmonary function test. Sometimes we do request some allergy testing. It really, the evaluation is really based on the clinical suspicion. There are some what we call red flag when we should worry when we see one with a chronic cough. If someone reports that they are coughing blood, then we will be concerned. If someone reports weight loss, difficulty swallowing, if one is a smoker, then we may have more worrisome potential diagnosis and require a more advanced investigation. Depending on the situation, if we're thinking that someone basically has allergic rhinitis and postnasal drip, treatment will involve allergen avoidance, antihistaminic, and use of nasal steroids. If we're thinking that we have someone who is dealing with reflux, we will do some counseling about avoiding some food that can trigger those episodes of heartburn. And very often, we will offer a trial of medication. And this actually can also be a way to really establish the diagnosis. If we're thinking about asthma, we will use different medication geared to treat their underlying airway disease. Other causes of chronic cough include COPD medication, and we at Baystate have a special interest into bronchiectasis. Bronchiectasis, I apologize for that. Bronchiectasis is a lung condition that can cause chronic cough. Individuals presenting with bronchiectasis will not only report a cough, but a cough also that is productive, typically of a significant amount of phlegm. Those individuals also tend to present with recurrent, frequent respiratory infections. So what is bronchiectasis? So people who have this condition, their airways are dilated or damaged. Their airways are larger than usual, and that can lead to accumulation of mucus, thus the production of a significant amount of phlegm when they are coughing. So this is actually a little illustration of an airway that has a bronchiectasis. So we have a normal airway to the left, and on the left we can see the damaged airway, which is dilated and also quite inflamed. So we describe this as the vicious cycle. So we have an abnormality of the airway. The airway is dilated with accumulation of phlegm. This leads to persistent inflammation, which favor and facilitate the colonization of bacteria and lead to chronic infection and subsequent with different organisms. This will create the vicious cycle where recurrent infection will damage further the airway and the whole cycle starts again. There are numerous causes of bronchiectasis. Genetic diseases. A prime example of people who have bronchiectasis are people who have cystic fibrosis. Some individuals will develop bronchiectasis, damage of their airway due to issues related to their immune system, who have a decreased ability to fight infection, and therefore will develop frequent infection, leading to damage of the airways and that recurrent cycle that I reviewed earlier. Some patients can have a fairly localized damage of their airway due to prior infection. A prime example is if someone had a very severe pneumonia. As a sequela of that pneumonia, they can have damage of a part of the lung and dilated airways, therefore bronchiectasis. Tuberculosis is another frequent cause of bronchiectasis. People who have recurrent aspiration can also develop bronchiectasis. And chronic infection, such as the one that will be discussed subsequently, atypical myobacteria, can lead to bronchiectasis. In about 40% of cases, however, the cause of bronchiectasis is not known, and these cases are called idiopathic bronchiectasis. So what are the symptoms of bronchiectasis? As I mentioned earlier, a chronic cough. One can also have associated shortness of breath. Some individuals will present with frequent bronchitis and other lung infection. Individuals may present with coughing blood, and that actually is a quite common symptoms in patients who have bronchiectasis. How do we go about to investigate when we have a patient that has bronchiectasis? In order to really establish the diagnosis, you need a special kind of scan, a CT of your chest, that will allow us to see the structural abnormalities, the dilation, the airways that are distorted and dilated. We often will ask also, because those patients present with frequent infection, you will see that at the clinic we routinely will obtain sputum cultures. We also will request different type of blood tests to try to elucidate the cause of bronchiectasis. And lastly, we often need to know how the people's lung function are, and we will request a pulmonary function test. So how do we treat bronchiectasis? So we first need to address the chronic infections, and for that we use different antibiotics that can be taken either orally, sometimes through the vein, and we also sometimes can prescribe antibiotics that are administered by inhalation. The main, a very important aspect in treating bronchiectasis is having adequate airway clearance We call that chest physiotherapy that will allow patients to loosen the mucus and expectorate. We often offer pulmonary rehabilitation where patients can learn how to manage their disease and how to properly address and identify symptoms that require an acute intervention. It is a chronic disease, and therefore patients have to have the ability to really understand and manage their disease. Dr. Green is now taking over and will discuss atypical mycobacterial infection. And thank you again for joining me.
Well, thank you, Dr. Liautaud, for that presentation. And thanks for everyone who has decided to attend this evening's presentation. We want to talk about non-tuberculous mycobacteria. It's one of those rather complicated bugs that we see in the pulmonary clinic, and particularly in our bronchiectasis and NTM clinic, NTM for non-tuberculous mycobacteria. Patients are often confused when they have the diagnosis of non-tuberculous mycobacteria, and with good reason. When one has a viral infection, that's something that it's pretty common. We've got a handle on that, right? Flu, COVID, we understand that. RSV is an infection. That's pretty common. A walking pneumonia, a walking bacterial pneumonia, that's well known. If the doctor says you've got a fungus in your lungs, the patient is very familiar with that. It sounds serious, needs to be treated. And if we hark back to TB, everyone understands tuberculosis as a disease. But the non-tuberculous mycobacteria, they're pretty odd bugs and require some thought and do take up a fair bit of time because the care is somewhat complex. I wanted to reprise Dr. Liautaud's vicious circle. In the 1980s, Dr. Cole constructed this rather elegant explanation for bronchiectasis, and we're focusing on non-cystic fibrosis bronchiectasis this evening. I'm going to call it bronchiectasis for short, and going forward, the non-tuberculous mycobacteria, I'll refer to it as NTM. And Dr. Cole thought that the lung was, in fact, when I went to medical school in the late 90s, we were still teaching that the lung was a sterile organ. And therefore, what led to bronchiectasis, he thought, was some infection, some bug getting into this pretty sterile place and creating a cycle of inflammation, causing the mucus to become very thick, very viscid, very gooey, preventing the lung from clearing that mucus, and then setting up a stagnant pool of mucus, going on to amplify that cycle. And with the inflammation, substances are produced which help to weaken the wall of the airway, leading to bronchiectasis. We've improved in our understanding of how the lung really works since that time, because using powerful tools, not just attempting to grow things from sputum in the lab, we understand that the lung is not a sterile place. I'd like to draw the analogy between the lung and gardening. Now, every good gardener knows that monoculture is not good. If you were to plant in your garden an entire field of tomatoes, there is a very high chance that some fungus will come along and destroy that crop of tomatoes before harvest time. Good gardeners know that having polyculture, multiple things in the garden, prevents infection, results in higher yields and better tasting vegetables. The lung is pretty much like that. Within the lung, you've got organisms, various bugs, growing in a restrained fashion. And that complex arrangement of bugs, it elaborates proteins and other substances from the body, which are beneficial to lung health. It also prevents strange bugs from landing within the lung and having runaway growth, leading to that kind of inflammation, which then sets up the situation for bronchiectasis. The bugs, the type and the number of bugs in a particular lung in a particular person, remain remarkably stable over the lifetime of that person. And so this is an important concept that we've now come to understand. When the number or the type of bugs within the lungs become altered for whatever reason, let us say the person is malnourished, or there is introduction of strange antibiotics, new environments, or as in any garden, you've got an overgrowth of strange weeds which are blown by the wind, then that intricate balance of organisms become impaired and disease sets in. Good gardeners also know that the soil is important, preparing the soil, and gardeners have endless debates about how to prepare a good soil. The mucus within the lung represents that soil, which has to be optimized and maintained in order for the correct balance of organisms to grow in the lung. So we've moved on from the vicious circle to this vicious vortex. The one thing you must take away from this is that lung health is a really, really, really complex topic. We are still trying to understand the finer workings of the lung and trying to tame that or to harness the information that we've gathered to improve lung health in patients with bronchiectasis. We now refer to it as the vicious vortex. I'd like to move on to discussing phlegm. You know, phlegm seems to be this amorphous thing that creates in most of us this ick factor. It's just there, it's just a blob. And it seems that it is pretty much rather simple and not much to be considered. But phlegm is rather a very complex result of bioengineering. These diagrams, the top panel, illustrates what the really basic molecules of phlegm look like. It is made of chains of carbon with some proteins and some acids stuck onto the end. And then they are arranged and folded and crumpled into whorls and blobs and sheets within the lungs. And that phlegm, that mucus, sits on a rather thin layer of fluid, which allows the mucus to slide from deep within the lungs all the way up to the throat where it can be coughed or swallowed. As in all complex things, complex states, many things can be broken, many things can go wrong. Therefore, the phlegm is an important thing to be considered in patients with bronchiectasis. Alterations in the thickness of the phlegm, alterations in the concentration of the various molecules within the phlegm can cause disease. And if we go back to our understanding or analogy of soil in the garden, if you've got poor soil, or if the soil becomes altered because of a spell of drought, or too much rain, or too much of one fertilizer, or too little of some nutrient, then every gardener knows that some things will grow more than others do, and that delicate balance is lost and a disease can set in. And so, how does your garden grow? Really is the analogy within the lung. What are the organisms that are within the lung? What are the types of organisms? And how many of them, of each type of organism, lies within the lung? That takes us to the third panel way down, with the pink representing the walls, the cells within the walls of the airway, and those pretty colored things, the bacteria within the airway. You can see on the lower left panel, you've got multiple organisms, this polyculture, as in a garden, restraining the entry and the proliferation, the excessive growth of any one organism, thereby preventing disease. You can see clearly in the lower right panel, there is that purple grenade-looking structure. These are multiple types of one organism. Like a weed, it predominates. It chokes out the growth of the other healthy organisms. It reduces the elaboration of the various proteins and chemicals within the lung. It creates disease. It sets up infection and inflammation within the lung. The white blood cells, they've got no choice, right? They're like policemen. And when there's too much of an organism, whether it's an organism that was already present in the lung in health and has become overgrown, or it's a new, virulent, rapid-growing organism. The white blood cells within the lung, they've got no choice but to act as policemen and try to handcuff and jail that organism. But when they get there, as in every brawl, somebody dies. The white blood cells die. They release their contents within the airways, and this further thickens the mucus. With the mucus being so thick, you can see in the middle panel marked C. I hope you can see that. These fine hairs have to ratchet back and forth, and move the mucus from deep within the lung towards the throat. If therefore the mucus is quite thick, it is very unlikely that the mucus will be moved at the pace or at the volume that it should be, and therefore you're creating these stagnant pools of mucus within which organisms can grow. It sets up great conditions for organisms which shouldn't be growing rapidly within the lung. It impairs lung health. It creates inflammation, which therefore weakens the walls of the airways, creating disease, the so-called bronchiectasis. You then will say to me, well, Dr. Green, how important is this thing? I've probably never heard of bronchiectasis before I came to this talk. Or if you've had it, you may not know 100 people with bronchiectasis. This cartoon demonstrates a survey trying to understand how many people are living in the United States with non-cystic fibrosis bronchiectasis. Before I go through the cartoon, I'd like to use an analogy. Let's suppose you're a sheep farmer, and I'm sticking with the farming gardening routine. Let's suppose you're a sheep farmer and you're a shepherd. You want to know how many sheep are within a fold. One way is to count every sheep in the fold, but it might be time consuming. But you decide to stand at the gate of the sheepfold and count the first 100 sheep that are coming through the gate. And you want to know how many spotted sheep are within the fold. So you count the first 100 sheep and you count 15 sheep, 15 spotted sheep coming through the gate. You know that you've got 1,000 sheep within the fold. And so you make a simple assumption that the mixture of spotted plain sheep coming through that gate represents what's happening within the fold. Can't be exactly true, right? You're making some assumptions which may not hold. But you generalize that and you say, well, there's 100 sheep coming through the gate, 15 of them are spotted. I know I've got 1,000 sheep. There are 150 spotted sheep, more or less. This is what this represents. And so this data suggests that there are about 340,000 people in the United States with non-cystic fibrosis bronchiectasis. And then you may say, well, there are 330 million people in the United States. That's less than 1% of the population with non-cystic fibrosis bronchiectasis. Why are you so concerned about this? Well, if you're living with non-cystic fibrosis bronchiectasis, you wouldn't say that because your life is pretty miserable. But it's a reasonable question to ask. I will tell you that every year, 8% of new patients are being diagnosed with this disease. It means that in about 7 to 10 years, we'd have doubled that number, bring it right to somewhere under 1 million patients living in the US with bronchiectasis. So that's important, right? That's significant. And if I further tell you that every other year, any single patient will be admitted to the hospital, then you say, no one wants to be admitted to the hospital every other year. If I also tell you that roughly $5,500 are spent per admission, then you will begin to think, well, now that's $1.8 billion a year spent on hospitalization for bronchiectasis. And then you begin to see the real importance of bronchiectasis to us as pulmonologists. We know that a large proportion of the patients with this disease are females over 65. But I will tell you from personal experience, and Dr. Liautaud will back this up, that patients don't read the book. And we've got many young patients in the clinic with bronchiectasis, many young male patients with bronchiectasis. And so it's a clinically important disease. Well, how about Massachusetts? The disclaimer, remember our sheep at the gate, right? This is a guesstimate. Between 2000 and 2007, this survey was done. And you can see that we're in Massachusetts, so I'm not going to point out where the state is, but you can see that Massachusetts has one of the highest rates of bronchiectasis within the country. So it is clinically significant for us as pulmonologists to recognize and to manage this disease appropriately. Dr. Liautaud crossed over this, and I'd like to say, I've struck out cystic fibrosis because cystic fibrosis is a poster child, right? It is well recognized, well advertised. Everyone knows about cystic fibrosis as a cause of bronchiectasis. I will tell you, though, that within our clinic, we find a significant proportion of our patients, probably 20%, probably up to 30% of our patients with bronchiectasis, so-called non-cystic fibrosis bronchiectasis, who have a trait, who are carriers for cystic fibrosis. And probably 1 in every 1,500 patients will have a new diagnosis of cystic fibrosis in adulthood. Because the presentation of cystic fibrosis, classically, you think about it as a disease which causes difficulties within childhood. And therefore, this is recognized and there's genetic screening as a routine and it's picked up by providers in childhood. But some patients have rare variants of the cystic fibrosis gene, and the diagnosis is made in adulthood when they present with bronchiectasis within that clinic. My talk focuses on infection, the NTM, the non-tuberculosis mycobacteria, as a cause of bronchiectasis. In parts of the developing world, tuberculosis represents the largest cause of this kind of bronchiectasis, the non-cystic fibrosis bronchiectasis. Well, of patients with bronchiectasis, how many have NTM? This survey suggests that about 7%. You can see here where my red arrow sits, that's a small slice of the patients with bronchiectasis. That's important because it has bearing on why we have this clinic. If you've got a disease that's not very common in the population, chances are a broad base of providers may either not have seen or heard or have comfort with managing this disease. And therefore, there is value to having this disease managed by providers who see this routinely and are aware of the nuances of the disease and the available therapies and beyond. The non-tuberculosis mycobacteria, I'm going to ask you not to be frightened by this diagram. It looks fairly complex, but it's actually rather simple. It's a big group of organisms. About 175 different organisms are grouped together as non-tuberculous mycobacteria. Some of them are siblings, some of them are cousins, and others, they're just living in the same room together. You can see here this inner red line. Look at that 1, 2, 3, that red line, inner red line, three rings from the exterior. And the reds represent those elements of that group that cause disease. It's about 80% of that group which cause disease. They cause disease to of varying degrees. They are the so-called slow growers, which are seen as the green in the second ring from the outside, which tend to as yellow, from the outside, which tend to grow rather slowly, and the disease may progress slowly. And probably in some of these patients, about 30% on average, up to 50% of these patients may actually clear their disease without antibiotic therapy. And so it becomes a very nuanced conversation about when to treat and which of these organisms to treat. On the other hand, those in the green, that second ring from the outside again, the green, tend to grow fairly rapidly and can cause pretty significant and rampant destruction in the lung within a short space of time. These are, of course, generalities. Some of the apparently slow-growing organisms can cause pretty significant disease in a short space of time. Because again, what is it that restrains these organisms? It is your immunity. And if your immunity has waned, then there's very little restraint. It is about the soil, the phlegm, the airway, the local environment in which they're growing. If you've got diseases that impair that local environment to a degree that enables the growth of these organisms, even the slow growers can cause pretty significant disease. Now you may say, well, that's 175 different organisms. How do you keep track of them all? And how do you figure out how to treat them? Because the antibiotic therapy for them varies within organism groups. Well, thankfully, most of the disease is represented by the so-called Mycobacterium avium intracellulare complex. I'll go back one slide, and I've ticked it off here, that second yellow ring, and here I've put the arrows in for myself. And you can see that it's within the slow grower group. The disease tends to cause inflammation and lung destruction moderately slowly. I'm sure there's a better term for that. Intermediate growth, and the destruction pattern is not as rapid. And so this looks at populations across the world. And here, North America is represented, the second circle from the top. And the Mycobacterium avium intracellulare, the bug that I showed you previously, it is represented by that light blue area. And this suggests that about 52% of the organisms are caused by the Mycobacterium avium complex. So that makes treatment of the disease somewhat more uniform. So what is MAC lung disease? We've gone through a fair bit of this. It is infection caused by a really heterogeneous and complex group of organisms. Where are they found? They're found in house dust. It is one of the reasons why elderly females represent one of the largest populations of patients with non-tuberculous mycobacteria, because they tend to do the housework. And the mycobacteria are contained within the house dust, within the soil, so gardeners are at risk. It's also contained within shower heads. One of the reasons we believe that this disease is on the increase is because potable water delivered to homes is commonly treated right across the developed world, and increasingly so across the developing world. And so as the routine bacteria are removed, the non-tuberculous mycobacteria, they have a profound increase in the number of organisms within the water. It comes through the shower head. It lives on the nozzle. And most people have their water turned to somewhat lukewarm temperatures. And that enables the growth of the microorganisms within the shower head. Once you turn the shower head on and it begins to mist, then that mist drives the organisms deep within the lung and can cause an increase in the non-tuberculous mycobacteria. So permanent lung damage can result. It is one of the reasons why we're interested in this disease. It's one of the reasons why it needs to be treated. I did tell you that about 35%, and on the higher end, 50% of patients can clear the organisms given time. And probably 5-10 years ago, we were less aggressive about initiating therapy in patients. But we've come to realize that as patients live longer, the disease has a fair amount of time to progress. And so towards the 7th, 8th decade of life, the patients have tremendous disease. And so it's important to halt the progress of that disease by initiating therapy earlier. Our talk, the main heading is cough. And cough is one of the main symptoms of this non-tuberculous mycobacteria. Some patients will have a dry cough, which is one of the most frustrating things that one can have. Some patients will have phlegm, which is thoroughly embarrassing in social settings. And then a significant minority of patients will have night sweats, weight loss, chronic pain, chest pain, and may even cough up blood. Things that help to cause the disease to progress is an impairment in one's immunity, a background of bronchiectasis, reflux disease, and other kinds of systemic disease. How do we diagnose? We diagnose using endoscopic procedures such as a bronchoscope under sedation within the operating room, the minor operating room. That procedure takes about 15 to 30 minutes, and most patients can go home the same day. A less invasive procedure is sputum induction, where we give you very concentrated salt water through a nebulizer, which helps to pull water into the airways and gives us enough sample for testing. There are established criteria for diagnosing that disease, and in the interest of time, we won't go through it minutely. But suffice to say, one sample growing non-tuberculous mycobacteria oftentimes is not sufficient for making a diagnosis of disease, merely colonization. And that's not difficult because to understand at this point, because I did say that the lung has organisms growing in it. And at some point, you may have unrestrained growth of one organism. So we may capture that in the phlegm, but the second time we come back, it's not enough for us to capture, and it may suggest that there is not active disease. However, Dr. Liautaud told you that we do repeat the sputum cultures at regular intervals, and therefore, if we capture it a second time, then we can confidently make the diagnosis of disease. Our samples are sent either to the state lab or Mercy Hospital. And further on, they are sometimes sent to the University of Texas at Tyler. It means that our patients may find that it takes a while for us to make the diagnosis of NTM. It requires some patience with us in the clinic for us to get the results for testing, for diagnosing the disease. Should you see a specialist? We think you should. We think one of the most beneficial things you can do when you come to the consult is keep a diary of your symptoms. Be prepared to ask questions. Be alert to why you're being referred to the physician. These things do help. Any testing that you may have had previously from a prior pulmonologist would be tremendously helpful to us. The decision towards about treating, when to treat, how to treat. I've put a little star here. This is the shared decision-making model, and we do this a fair bit in the clinic because, as I did say, when to treat and what to use for treatment is still not firmly established. And so we have to have a rather long conversation about treatment regimens and the time to begin therapy. So this is a shared decision-making model. Your views are absolutely important. Your treatment options would be either oral or intravenous antibiotics. The cure can be permanent. Sometimes the disease recurs in about 30% of patients over a 5-year period. The disease sometimes recurs and we have to treat again. The phlegm. Treating the phlegm, clearing the phlegm. There is no substitute for doing that because as we discussed, the phlegm is impaired in patients with bronchiectasis. It results in entrapment of the organisms deep within the lung. And simply by clearing the phlegm using meticulous, a rigorous protocol for clearing the phlegm, it can actually help to eradicate disease along with antibiotic therapy. Education is important. One of the most important things for patients is whether they can still hug their family, hug grandchildren, whether the disease is transmissible. And for 99% of these organisms, it's not. We aim to reassure patients that it is not transmissible. Within our quaternary clinic at UMass Baystate, I'm going to make a shameless plug for it. We've got a whole raft of people that assist us in the clinic. I'd like to call out our nurses or nurses who work diligently in reaching patients, in making sure that the therapies are adhered to. Patients can reach out to them. We've got physical therapists and dietitians. We don't do this alone. There's a team sport. We've got other physicians nested within the clinic, infectious disease attendings, radiologists, the thoracic surgeons are indispensable in helping us to eradicate disease, the primary care physicians who can appropriately help to identify and refer patients, and our colleagues, the general pulmonologists, who can refer patients to us. Our external partners are here. They are within state and further afield. Why do we have this clinic? Well, there are so few patients in the United States that have this disease that local expertise is needed. We've pointed out that Massachusetts has a high prevalence of the disease. Being within the quaternary clinic allows patients to have access to clinical trials, cutting-edge therapy. Currently, we have 3 trials. One is active, one's closed, and the other one will be coming on stream soon. We aim to have a registry of patients so that we can properly identify patients who would benefit from future trials, and no patient will be entered within this registry or utilized for care, disseminating their private information without consent. So I'd like to reassure patients, anyone who considers being a patient and a part of this registry, that this is something that we take seriously. And if you've got any desire to be seen in the clinic, here is our number. We are happy to see you for a one-time consult and then send you back to your treating pulmonologist. And that brings us to our end. Thank you, everyone, once more.
Thank you both for that excellent presentation. Really great information. I'm kind of wowed. Our audience already has some questions in the chat, in the Q&A box, but just to remind you that please type in your questions and Dr. Liautaud and Dr. Green will provide answers. So the first question in the queue is, when would you consider an environmental exposure to mold as a cause for chronic cough?
So would you, I'll defer to you as first responder. Unmute.
Oh, you're on mute, Dr. Liautaud.
So we typically do look at the environment, and especially like when we have patients who present with, asthma, we very often look for clues in their home, whether or not there are sources or environmental exposures that could explain sometimes the difficulty to control their symptoms. In those situations, a mold actually can be a consideration. It may be sometimes difficult to establish the link, however. So one has to be very kind of careful in trying to get an understanding and also see whether or not we can kind of have a specific the timing, the onset of the symptoms in relation to the exposure. So it's not always straightforward, but yes, we do take that into consideration.
Thank you.
I'd like to support that, Sybille. One of the interesting questions I've been asked within the clinic is, for example, patients who are in congregate housing where there has been water damage and you can clearly see the black mold on the wall. And oftentimes it's patients who've probably had this protracted conversation with a landlord who refuses to fix it. And now they've got a chronic cough. And with or without bronchiectasis, it is an important question. It clearly is an important question. We do know from the literature that a moldy environment, the so-called sick building syndrome, can result in a chronic cough and feelings of just being unwell. It is best, it's a diagnosis that we can confidently make if there are multiple people within that environment who are sick within that same time period with some relation to the onset of the mold. There are these commercial kits which you can buy, which tell you, the levels of mold within the environment. And at this point, no one knows exactly what to do with them. Probably 3 years ago, I was at a conference of people who do research in this, and today the state of the art is that it's very difficult to tell which type of mold, how much mold. Black mold is always a concern. It's very difficult to tell this. But there are certain kinds of molds, particular kinds of molds, aspergillus, when found deep within the lung in patients with bronchiectasis. It's important to treat that. There are some other moles which we're not quite certain what their import is. And at the present, the general feeling is that they're just living there in this kind of polyculture and do not actually represent the disease.
Thank you both for that. The next question, I believe, is related to the MAC lung scenario. And the question is, could it end up causing lung cancer?
Should I take that, Sybille?
Yeah.
MAC clearly causes severe lung disease, severe disabling lung disease. It has not been proven as yet as a driver of lung cancer. That's a straightforward answer. But of course, data on that keeps evolving.
Very good, thank you. The next question, how common is it for someone to live with this undiagnosed, I believe also referring to MAC, into their later years?
I'll defer to you, Sybille.
So actually, it's not unusual to be diagnosed of NTM and MAC specifically in your older, years. And in fact, one of the description of this disease is in older women who would present with very characteristic features that are really kind of very lean, very small, and who have this chronic cough. In fact, in our clinic, we do see a fair number of individuals in past their 60s presenting with this disease. The other thing that people need to understand is because the symptoms, are chronic, and there's not some, physicians are not really in tune with this diagnosis. So the diagnosis tends to be established much later because you do have to you have a suspicion in order to look for it. And if, you don't look for, certain condition, then the diagnosis may occur much later.
Very good, thank you. So there's actually two questions on this same topic, which is, what is it about Massachusetts that's creating or driving up the numbers, for a high rate of NTM or, this lung disease in particular?
Maybe in Massachusetts we've got better quality potable water. That might be one answer. And so the levels of the organisms within the potable water is increased. Could be. People have pondered that question as to why MAC seems to be increasing in the developing world, and yet in the developed world and in areas of the developing world where there are large academic centers where people search carefully, they don't tend to find it as commonly. And it may be that the water is just too clean. The other thing too is probably increased recognition of that disease. You do find that on the coast of the country, east and west coast, there are these academic centers where persons like Sybille and myself are interested in this disease, and we increase public awareness, and so the incidence seems to be increasing. Time will tell, because these studies are ongoing, looking at the Midwest and those other areas to see what the incidence of MAC is. In Hawaii, though, it has, if you saw the diagram, it has one of the highest incidences of MAC in the country. And in Australia, among the native population, the First Peoples, there is a very, very high incidence of MAC in that population. So clearly there is a combination of genetic factors, occupational factors, social factors, including physician awareness, that seems to drive up the disease.
Thank you. The next question, is a dry cough or productive cough more common?
So that's actually a tricky question. So I guess I would say that it depends on, I guess, on the population. Like for us, we may be thinking more that we see more patients with productive cough, but just because of the nature of the type of patients that are referred to us. So I cannot really honestly, answer these questions. Maybe O'Neill, you may have some insight into that.
With respect to bronchiectasis, we talk about wet and dry bronchiectasis. Wet bronchiectasis is a classic one where one has a great deal of phlegm, but dry bronchiectasis is said to be of lesser frequency. However, with important caveats, right? We go back to Dr. Liautaud's comment about bronchiectasis coexisting with other primary diseases. So up to 60% of patients with COPD will have some degree of bronchiectasis. And well, what is one of the symptoms of COPD? It's a cough. And so, I think the reflection that dry bronchiectasis is in the minority might be because of how we sampled the data. There's also the feeling that certain populations historically tend to underreport symptoms, underreport phlegm, because phlegm is seen as socially embarrassing. And therefore, when asked if they make phlegm, they seem to say, no, not a lot of phlegm, because it's not socially done thing to say that. So I think our data showing that dry bronchiectasis is in minority might just be reflective of that.
We only have a minute left. If you want to take one more question, the next one is, I would assume, referring to MAC, that can this be caused from use of a CPAP machine?
Sybille?
I have not come across, any data to suggest that. However, we know that when we're using a CPAP machine, we also use a humidifier, meaning that we have a source of water. So it is theoretically, not possible, but I would say that it's not very likely. We don't have any data to establish such an association.
Yes, the growth characteristics of the MAC make it very unlikely that they spread from device. In fact, of the 170 plus different members of that group, there's been only one that's been associated with an outbreak done by careful genetic analysis of the organism across various devices and with the patients. And that's the abscessus group, which was at the Royal Brompton, somewhere between 8 to 10 patients who had cardiac surgery had the disease spread from devices. And particularly because abscessus has this film which clings to devices and can cause disease, but the growth characteristics of the rest of the MAC make it unlikely that they're spread from CPAP.
Very good. Well, we're out of time, but one of the comments was that they thank you for your efforts and that they enjoyed it, and so did I. I hope all the audience enjoyed it. So thank you both for your expertise and for sharing your time. This was a fascinating talk, and we appreciate you.
Thank you very much.
Thank you. Thank you.